Hello, good morning everyone. Welcome back in Pediacemy by Dr. Pankaj. Myself, Dr. Pankaj. I'm pediatrician by profession and teacher by passion. So we are discussing this amazing series of NEET SS Pediatric Recall 2025. We have discussed part 1 where we discussed around 50 questions. Now we'll discuss remaining 50 questions of this series. This is very important because we are not just discussing previous year's question, we are just discussing previous year's topics also. So around these topics question has been framed and will appear in examination which are upcoming like INASS or upcoming NEET SS examination. So my request for all viewers is just stay away from distractions and give your 100% attention to this recall series because this is your attention is required. And for this effort, do like, share, and subscribe. Okay, so without further delay, we'll start our discussion of NEET SS Pediatric Part 2 recall video. Okay, so as we all know, uh, this legal disclaimer is there. Any resemblance to actual examination, past or future, is purely coincidental or unintentional. So we are discussing just NEET SS pattern-based questions. Okay, so question number 51. A infant presented with intractable vomiting, raised ammonia level in blood, following retina image is given. What finding is visible? Okay, so this is actually we are I think very much familiar with this image. Here it is given clearly. It is cherry red spot. Okay, so this is cherry red spot. In which condition it is seen? It is seen in Tay-Sachs disease, Niemann-Pick disease, central retinal artery obstruction, and trauma. Okay, so you have to be familiar with this cherry red spot and in which condition it is found. Next question, question number 52. Which drug is FDA approved drug for SMA and it is given intrathecally? Two hints are given in this there, like FDA approved drug with SMA and intrathecally. Answer should be Nugent Sarin. This is actually previously asked question also. We have discussed these SMA drugs and newer advances in our NEET SS neurology revision video. So just go through this video if you are not yet aware of it. Okay, we have discussed it. So, in this, we have discussed new SMA therapies are there. Each and every part of this slide is very much important because at least 7 to 8 questions, or I can say minimum 5 to 6 questions are there in this slide. Okay, first we'll talk about the drug Nugent Sarin. The brand name is Spinraza. Okay, the first question is the brand name. Second question itself, it is approved for all ages. Next, what is the dose has been asked. It is actually loading dose, 4 doses in 2 months, then every 4 months. What is mechanism of action of this? This is again the question is there. Antisense oligonucleotide promoting inclusion of exon 7, very much important. Another drug which has been approved by FDA is this onasemon. This is actually the complex name and the brand name is Zolgensma. Okay, again, it is approved for less than 2 years of age. Very much important. This drug is IV, one time dose, and mechanism of action of this drug is gene replacement therapy using AAV9 vector. Again, these everything is important which I am uttering or discussing with you guys. Next drug is risdiplam. This drug is approved for more than 2 months of age. It is given daily, orally, and mechanism of action is small molecule splicing modifier promoting inclusion of exon 7. So again, pause this video and go through this again because it is very much important for upcoming examination. SMA is hot favorite topic of examiners. Okay, next question. A 12-year-old child met with road traffic accident. The following CT image is suggestive of. This image we are discussing about. This is a biconvex image in intracranial hemorrhage. It is clearly extradural hemorrhage. Okay, how we will discuss? Just see, this is biconvex extradural hemorrhage, and this is actually crescent shape. This is subdural hemorrhage. This is intraparenchymal hemorrhage and subarachnoid hemorrhage. We'll discuss this. Okay, so as we discussed, biconvex, crescent, and star shape. It is the shape of the hemorrhage in EDH, STH, and SAH respectively. Okay, then other main things, vessel ruptured. In EDH, middle meningeal artery getting ruptured. In STH, bridging vein ruptured, and SAH, circle of Willis arteries aneurysm are getting ruptured. So this is actually a very important topic. These images of EDH and STH, these are actually frequently asked. So just go through them. Next question, question number 54. An infant presented with cutaneous lesion suggestive of spinal disc raphism. Imaging is not required. Options are lipoma, hair tufts, coccygeal pit, aplasia cutis. Again, this is recall from our NEET SS pediatric neurology revision class. Okay, where we discussed this. This is the screenshot of same class. Okay, so just go through in which condition imaging is not required. In simple dimple, less than 5 millimeter, more than 20, less than 25 millimeter from anal version, coccygeal pit, which is our answer. So in coccygeal pit, it is not required, but now they are asking coccygeal pit. Again, in next exam, they will ask in simple dimple less than 5 millimeter, more than 25 millimeter from anal verge, imaging is not required. And just remember, imaging is indicated in which condition. Okay, in subcutaneous mass of lipoma, hairy patches, dermal sinus and cyst, atypical dimple. Just see atypical dimple description. It is D, more than 5 millimeter, more than 25 millimeter from anal verge, vascular lesion, hemangioma and telangiectasia, skin appendages in polyploid lesions, and scar-like lesion like aplasia cutis. So, aplasia cutis and dimple examples can be asked next exam. So just see this, pause this video and memorize this table or remember this table. Okay, going forward to next question. Okay, so one thing I want to discuss, we have discussed part 1 video. There are many actually um, wrong question or wrong explanation I have given in this that video, but just it is a recall issue. Just we will discuss all the controversial or wrong question in the I think end of this video or next video. Okay, so the crux of these recall videos is getting you prepared for upcoming topics, not the exact questions. Okay, so we are discussing topics along with, obviously questions are same from the this exam, but actually topics are very much important. So stay tuned. If you are not awake, so just keep your distraction away. Just go through this intense around 1 hour class and you will be benefited from it. Okay, next question. A child presented with cholestasis with lymphedema of feet. So this combination, basically keywords has been asked. This combination, cholestasis with lymphedema of feet, is important in this condition. The diagnosis is Agonis syndrome. Okay, so you are able to see this pitting edema. So some keywords you have to remember. Going forward to next question, an infant had symptom of cholestasis. What is the vitamin K dose in this case? Okay, so actually we are referring to Indian Academy of Pediatric. What it says in neonatal cholestasis, vitamin K dose. Just see this: 2.5 milligram twice a week to 5 milligram per day oral, or if we have to give IV or IM dose, it should be 2 to 5 milligram per month. Means oral and IV drugs are given separate, but in this question it is not mentioned. Okay, so by all these options I will go for daily 2.5 to 5 milligram. It can be weekly, Basically it is range we have to remember, 2.5 milligram twice a week to 5 milligram per day oral. In other texts it is given alternate day, 2.5 to 5 mg, so it's up to you. I am referring just Indian Academy of Pediatrics. Okay, next question, question number 57. In newborn is 850 gram weight, birth dose of menadione. Okay, so in this scenario, again I'm referring to AAP and MOHFW. American Academy of Pediatrics says the single IM dose of vitamin K is 0.3 to 0.5 milligram per kg for preterm infant weight less than 1 kg. Okay, again MHFW says for babies weighing less than 1 kg, dose 0.5 mg is recommended. Okay, so according to MOHFW, 0.5 mg dose is recommended. According to American Academy of Pediatrics, 0.3 to 0.5 milligram per kg for preterm infant less than 1 kg. So, in our discussion, answer should be 0.5 mg. Going forward to next question, question number 58. In neonate presented with respiratory distress at birth, CDH was suspected, congenital diaphragmatic hernia was suspected. How you will proceed further? Bag and mask ventilation, intubation, TPs, and tracheostomy. So you are able to see this CDH. We are very familiar with this CDH because this is common occurrence in our NIC units. Okay, everybody know bag and mask ventilation is contraindicated, so this is contraindicated. TPs is also not that good. Tracheostomy, then bag and mask ventilation, why? No. Intubation, because patient is also in respiratory distress. The crux of this question or this discussion is we have to avoid bag and mask ventilation in congenital diaphragmatic hernia. Okay, going forward to next question. Okay, I'm going very fast to discussing these topics, otherwise I will not be able to complete or conclude all remaining questions. Okay, if you feel I'm somewhere I'm going fast, just pause this video and rewind the stuff again. You'll get benefited from it. Okay, so congenital nephrotic syndrome, the gene is associated with which gene? Okay, so they are asking gene in congenital nephrotic syndrome. Okay, let me tell you, congenital nephrotic syndrome, the definition, they start at birth, manifestation start at birth or in first 3 months of life. These two conditions should be satisfied. Primary congenital nephrotic syndrome, it is genetically inherited and the most common mutation is NPHS1 nephrin gene. And Finnish type of congenital nephrotic syndrome, independent question has been asked, which is Finnish type, what is the gene which is most common. So in this slide again 3 to 4 questions are there, you have to remember. Okay, NPHS2 is podocin, which is our answer in this question. WT1 Wilms tumor, Denny-Dresch syndrome, LAM2 is Pearson syndrome. So congenital nephrotic syndrome is itself an important topic you have to revise and remember for upcoming exams. Next question, question number 60. A child presented with cola colored urine, hypertension following upper respiratory tract infection. What is not true? Clearly they are talking about PSGN. Okay, so in PSGN many conditions are seen. Just go through the option. ASO rises in 70% cases, subepithelial hump seen, high C3 titer, symptomatic management. First we will see about C3. Okay, we will see in which condition C3 is getting lowered. Just remember this high yield table from Nelson. C3 is lowered in lupus nephritis, subacute Beck's Sabe, shunt nephritis, essential mixed cryoglobulinemia, visceral abscess, PSGN, and MPGN type 1. Remember, not in type 2. Just pause this video and revise and remember, try to remember in which condition C3 is low. Okay, so in our question, high C3 titer is not the answer. Okay. This table we have also discussed in nephrology fast track revision for NEET SS Pediatrics. This was our first slide. The screenshot of same is here. Okay, we'll not discuss the whole table, we'll discuss just PSGN. Just see about PSGN, it is seen in all ages. Acute nephrotic syndrome seen in 90% cases and nephrotic syndrome seen in 5 to 10% cases. Again, this is potential question. In what percentage of patients nephrotic syndrome is seen in PSGN? Answer should be 5 to 10%. Just remember. So we are not just mugging up answers of this exam. We are discussing the potential questions around these topics basically. So again, hypertension is seen in 60% cases, but previous years asked question, hypertensive encephalopathy is seen in only 10% patient. Laboratory finding, ASO titer is increasing 70%, not 100%, 70%, which was in our question also. And C3 to C9 is low, C1 and C4 are normal. Electron microscopy shows subepithelial humps. Okay, so again, we are discussing NEET SS recall questions. So this demands your very attention, and because we are discussing very lot of stuff, lot of information stuffed in a short video, so just dedicate yourself to this video. This is very beneficial. I have collected various tables, information from Nelson and other places at one place, so your time will not be wasted. Okay, going forward to next question. Which of the following statement about cardiac looping during embryonic heart development is true? Basically, this is embryology question, but in our exam, they sometimes ask embryology questions also. So just go through these options. Looping occur to left side. During looping, left ventricle align from truncus arteriosus. Asymmetrical signaling regulates the direction of looping. Cardiac looping starts at 5th week of gestation. Okay, first see, it is not left side looping, it is dextral looping. Okay, just remember. And this is actually left right asymmetry of heart is there. So looping occurs to right left side, it's wrong. Okay, asymmetric signaling regulates the direction of looping, true. Cardiac looping starts at 5th week of gestation, no, it is around 20 to 30 days, so this is also wrong. And during looping, left ventricle align with truncus arteriosus, no. So answer of this question is this. Okay, so basically if you want to learn this in detail, just go through embryology part of cardiac development. Okay, next question we're discussing, question number 62. MRI image was given. What is pathogenesis of this? First you have to identify this is actually lesioncephaly. Okay, lesioncephaly. So what is lesioncephaly? It is a developmental disorders due to cortical defect in migration. So basically it is neuronal migration disorder, very much important. What are the other conditions which are associated with neuronal migration disorders are heterotropia, lesioncephaly and cobblestone cortex. So these three you have to remember. These actually are potential question for upcoming examination: heterotropia, lesioncephaly and cobblestone cortex, which are neuronal migration disorders. Going forward to next question, question number 63. A child can sing a short poem, copy a square, dress and undress independently, engage in cooperative play. Okay, basically they are asking developmental milestone questions. I have discussed them in one video of mine, so you can refer to that. What I suggest you, because examiners are following Nelson for this milestone thing, so just go through Nelson table. I am giving you 4 years, what 4-year child can do. So answer of this question is 4 year. Just go through this. 4-year child can hops on one foot, throws ball overhead, climbs well, copies bridge from model, copies cross and square, draw a man with 2 to 4 part beside head, counts 4 penny, tells story, play with several children, with beginning of interaction, role play, goes to toilet alone. Actually, in this slide there are 5 to 6 questions they can ask. When child goes to toilet alone, when child count 4 pennies, 5 pennies. Okay, so it is very much essential for you all to go through these. I will actually help you in memorizing these by some mnemonics in later videos. Okay, but as of now just remember this. Going forward to next question. Infant with tachycardia, diaphoresis during feeding and poor weight gain. ECG shows deep Q waves in lead 1, AVL, ST depression lateral leads. Echocardiogram reveals left ventricle and reduced ejection fraction. Answer of this is L kappa. This is hot favorite topic of examiners. What I want to remember in this question is just remember this L kappa description in this deep Q waves in lead 1 and AV well, ST depression in ST leads. So this is actually description of L kappa pathological Q waves. You have to remember the clinical scenario along with ECG finding. That's it. Okay, so we are discussing again to remind you all, we are discussing NEET SS Pediatric recall series. Okay, this question has been asked. Again, this is screenshot of my nephrology recall video. Sorry, nephrology fast track video for NEET SS Pediatric. This exact image was picked up from Nelson. Okay, so they are given petechial rashes, abdominal pain, following images there. This is clear-cut diagnosis of HSP. In this palpable purpura is there, which is essential criteria along with IgA deposition. Okay, what we will discuss, the European League against rheumatology classification criteria of HSP. Okay, in this condition, the palpable purpura should be there in absence of coagulopathy and thrombocytopenia. This is essential. So this thing should be there. This is essential. Okay. Along with one of the criteria should be completed, like abdominal pain, arthritis, biopsy showing IgA deposition, and renal involvement showing hematuria or red cell cast. Very much important. Just pause this video and revise this again. HSP, it is very much important. Okay, going forward to next question, question number 66. Which drug is not advisable antenatally for mother with lupus to prevent neonatal lupus? Basically, they are asking neonatal lupus. We all know dexamethasone and IVIG has a role. Okay, so dexamethasone, it is advisable. Yes. HCQ, regarding HCQ will go forward to Nelson. Hydroxychloroquine is recommended in throughout the pregnancy for all SLE patients. Okay, so HCQ can be given. HCQ can be given. Dexa and terbutaline, yes, can be given. The answer, our answer of this question is leflunomide because it is teratogenic. Okay, so again, neonatal lupus is very important. Lupus nephritis stages are important. We'll discuss them. Okay, going forward to next question, question number 67. Again, I'm going very fast, but you have to actually pause this video at appropriate place to see what we are discussing or if you're grasping or not. 3-year-old child present with a low-grade fever, painful oral ulcers, and vesicular rash on palm and soles. A similar illness is reported in his daycare. Which of the following organisms most likely responsible for his condition? So basically, they are discussing hand, foot, mouth disease. You can see the visuals: hand, foot, and mouth. The organism responsible is Coxsackie virus A16. It is very much important. Coxsackie A16 virus. Okay. Going forward to next question, question number 68. If 5-year-old child came in OPD with acute gastroenteritis, physician should be cautious to prescribe antibiotic in which infection it may worsen HUS. HUS is hot favorite topic of examiners. Okay, so basically they want to ask in HUS antibiotics are contraindicated. So which is the most common organism causing HUS? All we know, answer should be E. coli 0157H7. For extra information, antibiotics are generally contraindicated, but potential question in adults, azithromycin, meropenem, rifaximin are used in exceptional cases. This is exceptional potential question for next exam. So again, I'm saying you all ki just see this video and just in comment down below, like you commented in first part of this series, any discrepancy, any new questions, any options. There you are most welcome to comment, because this is actually learning platform for all of you, and we want best out of whole the scenario. Okay, so just comment down below and your suggestions also. We'll be starting a new series of Nelson based and a neonatology based series also. We'll discuss important points there. So if you haven't subscribed this channel, just subscribe this channel and just hit the bell icon, because we will be discussing many things in upcoming days. Okay, so this question, I think, repeat RTA below CT images given, EDS should be the answer. Okay, next question, question number 70. A 15-year-old boy present with weight loss, palpable abdominal mass, sudden severe abdominal pain, imaging shows cystic liver lesion with free peritoneal fluid. What should be the diagnosis? I think it is clear cut. It is hydrated cyst which is ruptured. Okay. Going forward to next question. A newborn present with jaundice, failure to thrive, hepatomegaly, urine microscopy shows pyurean culture is pending. Okay, so I think we are dealing with UTI. They are clearly asking what organism most likely associated with UTI in this age group. Basically, they are asking in newborn which organism is responsible for UTI. Our answer should be E. coli. Okay. I am giving you additional point here. Nice 2022 guidelines for UTI workup. Okay, just see, this is high yield table. Age group has been defined less than 6 months of age, 6 months to 3 years and more than 3 years. To less than 6 months of age, if first febrile UTI is there, you have to go for ultrasound, and atypical to recurrent VCOG plus ultrasound. 6 months to 3 years, no imaging is required, and 6 months to 3 years if it is atypical, ultrasound plus VCUG. Again, more than 3 years, no imaging is required unless complex cases, be it first febrile UTI or atypical febrile UTI. Okay, going forward to next question, question number 72. Okay, so again, I'm going very fast. If you want to just revise previous stuff, just go through this section again, because I have to cover as many questions as I can cover in this video. Okay, so a newborn presented with recurrent tonic seizures, generalized stiffness and exaggerated response to light, photosensitivity. EZ is normal. There is no improvement of standard anticonvulsant. Options are paradoxin dependent epilepsy, hyperplexia, early infantile epileptic encephalopathy, and benign neutral seizures. Answer should be hyperclepexia. This is important. Again, question number 73. In newborn with pallor, cyanosis at day 2 of age with left axis deviation. Okay, we have discussed earlier also. Actually, we have to be focused on key points, because in exam questions are lengthy. So we have to be on the point with key points. Just search key point on this that question. Left axis deviation is the key point in our discussion. Left axis deviation. So left axis deviation along with described things clearly seen in tricuspid atresia. So our answer should be tricuspid atresia. Even if you don't know about other thing, just hold of keywords. Okay. We'll be starting a series soon about keywords in pediatric, where we'll discuss keywords and how you will catch them. Like for keyword, we have discussed for L kappa, for left axis deviation, and other things. Okay. Going forward, question number 74. A 10-year-old boy present with fatigue, muscle cramps, tetany. Lab shows hypokalemia, hypomagnesemia, metabolic alkalosis, hypocalciuria. BP is normal. Okay, in these type of question, basically this question is from tubulopathies, pediatric tubulopathies, which is itself very important topic for NEET SS and INS examination. We have to dissect it out. Okay, metabolic alkalosis is given. One option is renal tubular acidosis. So this is ruled out because alkalosis is not found. Again, BP is normal. Liddle syndrome In this Liddell syndrome, BP is raised, so this is ruled out. What is remaining? Bartter and Gitelman. What is the peculiarity of Gitelman is hypomagnesemia. So this is the key word here, hypomagnesemia. Again, I'm saying we have to pick up the keywords. So hypomagnesemia seen in Gitelman syndrome, our answer should be Gitelman syndrome. Okay, so this is actually table. Just go through this high yield table in Gitelman and Bartter. What is happening? So loop of Henle and DCT involved in respectively Bartter and Gitelman. Okay, hypercalciuria seen in Bartter and hypocalciuria seen in Gitelman. Very much important. Magnesium hypomagnesemia seen in Gitelman, again very much important. Prostaglandin is elevated, very important. Just go through this salient point. We have discussed this Barton, Gitelman and tubulopathies in our nephrology discussion of Nelson based videos, where I discussed in detail about Bartter and Gitelman syndrome, types of Bartter, type of Gitelman, and other treatment consideration. You can go through, because this is important topic. You have to be clear about this, otherwise this is very difficult to actually remember, and you have to go through with concepts. Next question, question number 75. A 1.4 kg preterm infant presents with anemia and marked reticulocytosis. I actually received this question incomplete. Iron, copper should be the answer. I don't know. So I'm leaving this question for you guys to complete and answer this question. Complete this question and answer in comments down below. Okay. So going forward to next question, a 10-year-old child present with focal seizures, MRI suggestive of neurocysticercosis. What is the line of treatment? Options are given below, like albendazole plus steroid plus carbamazepine, praziquantel, carbamazepine and IV antibiotics. Basically, I want all you guys to take IAP protocols of neurocysticercosis management, very much important. What they are saying, anti-seizure medications are only indicated in case of seizures, and the choice is oxcarbazepine or carbamazepine orally. Okay, so in our question, seizures were there. Anti-inflammatory, basic they are saying dexamethasone 0.15 milligram per kg per dose QID, or prednisolone 2 milligram per kg per day for 5 days. Cell therapy, calcified lesions is not required. Active lesions like vesicular, colloid and granular nodal stage, albendazole 15 mg per kg per day from day 3 to 7 to 14 days. So basically what they are saying, albendazole is required, steroid required, carbamazepine is required because history of focal seizures is there. Okay, so these are trapper words in question. You have to be thorough with guidelines, but again you can't be getting it wrong because you haven't read those keywords. Okay, going forward to next question, question number 77. A 6-year-old child present with progressive ataxia, areflexia, and peripheral neuropathy. There is no evidence of vitamin B12 deficiency. MRI brain is normal. So ataxia is vitamin E deficiency. You can see this vitamin E deficiency presents with ataxia. This is straightforward question. Okay, going forward to next question, question number 78. Which best describe the serological profile in a patient immunotolerant phase of chronic hepatitis B infection? Basically, they are asking about immunotolerant phase. Okay, so what is immunotolerant phase? Basically, liver inflammation and biochemical markers of liver are silent, means liver inflammation is not there, and SGPT is nearly normal, but high HBV DNA load, HBeAg positivity. So this is immune tolerant phase. In our case scenario, HbSAg positive, HbE positive, HbDNA high, and ALT is normal. So this is immune tolerant phase of chronic hepatitis B was asked. This is the answer. Okay, going forward to next question, question number 79. A 7-year-old boy present with periorbital puffiness, cola colored urine, and elevated blood pressure. So we have discussed this is altered sensorium seizures. So this is PSGN along with encephalopathy. Basically, directly they are asking what is the most common cause of encephalopathy in PSGN. Okay, just see in PSGN hypertensive encephalopathy and uremic encephalopathy are two causes of encephalopathy, clear cut. But out of them, hypertensive encephalopathy is important. And just remember 60 and 10 rule. What is 60 and 10 rule? PSG in hypertension. Hypertension seen in 60% of patients in associated with hypertensive encephalopathy in 10% cases. Very much important. Okay, going forward to next question, question number 80. Which of the following is most likely cause of hyperkalemia in a child of CKD? Okay, again I'm reminding very much important question. Any abnormalities in electrolyte or metabolic abnormalities in chronic kidney disease, they are asking mechanism behind. Nelson has given a beautiful table. I'm just discussing hyperkalemia here. Why hyperkalemia occur in CKD? It is due to decreased GFR, metabolic acidosis, excessive potassium intake, and hyporenemic hypoaldosteronism, which is most common cause. So in our case scenario, A should be the answer. Other time they can ask the high bone turnover disease. We have discussed this CKD in detail in our CKD video. You can go through Nelson based video if you want. Okay, this is actually additional point. If this is important because in we are discussing CKD definition, you have to remember kidney damage more than 3 months is required. 3 months is important. Okay, kidney damage like abnormalities in composition, blood and urine, imaging test, kidney biopsy, and GFR less than 60 for more than 3 months. You have to remember definition. The staging of CKD is important. Stage 1 to stage 5. Stage 1 more than 90 GFR, 60 to 90, 30 to 60, 50 to 30, and less than 15 or dialysis. So this staging is also important. So just remember staging and the diagnosis part. Going forward to next question. Again, this is hot favorite topic of examiners, renal tubular acidosis. We have discussed this renal tubular acidosis in detail. So this screenshot is from there only. In our nephrology part of pediatric based Nelson based revision and also the main videos, we have discussed this. What they are asking in type 1 RTA, which is actually most consistent finding, urine pH is less than 5.5, no. Negative urinary iron, no. Hyperkalemia, no. Positive urinary anion gap, yes. So just go through this table. I can't go into intricity of this topic basically, but just see. Potassium is high in type 4 RTA. First question. pH is more than urine pH is more than 5.5 in distal RTA. Second question. Urinary net charge is negative in proximal RTA, positive in other RTA. Next question. Fractional bicarb excretion is more than 10 to 15% in proximal RTA. Next question. And associated features like nephrocalcinosis and hyperglobulinemia seen in classical distal RTA. So 5 to 7 questions are from this table. It is very important. Just pause this video, and if you want to get clarified from the topic how it happens, just go through my RT video in the playlist. Okay. So this is a Lemery syndrome, which is best described. This is PYQ, again actually repeated PYQ. So this is classically thrombosis of internal jugular vein following oropharyngeal infection. So this is actually oropharyngeal infection that is followed by thrombosis in internal jugular vein, and Lemery syndrome is being called as its name suggests. Nasal nitric oxide is primarily used in screening test of which of the following? Okay, just see, these are trappers. Okay, we know Pheno is used in bronchial asthma, but it is not Pheno. It is nasal nitric oxide. So these type of questions are trapper. Our answer should be primary ciliary dyskinesia. Just go through this table from Nelson. In this, nasal nitric oxide during plateau less than 77 nanoliter per minute on 2 occasions of more than 2 months apart with cystic fibrosis excluded. This time they have asked this again. Next exam or IN exam they can ask the value of this. So just remember value of this. It is very much important. Okay, going forward to next question, question number 84. This is about mitral wall prolapse in children, which is true. The options are slightly controversial because exact recall is not available, but from available options, just see. It increases prevalence with age. It is commonly due to septal leaflet elongation. It always causes significant mitral regurgitation. It is more common in hypertensive children. So just see, in this condition, mitral wall MVP prolapse belonging of one or both mitral leaflet, especially the posterior cuff. So it is not septal cusp, it is posterior cusp. So this is not the answer, not true. Okay, uh, this is actually males with MVP increase risk of cardiovascular complication. Lesion is not progressive in childhood, but specific therapy is not indicated. Okay, so it prevalence with age, it is actually not true. More common hypertension, not true. Always cause significant mitral regurgitation is not that true. But prevalence with age is increased in sudden death, like heart failure. Okay, so this might be the answer. Okay, I'm leaving this question again with you guys. If you remember exact recall of this MVP question and answer of, just uh, type in comment down below if you have any clarity about this question. Okay, so this was crux is MVP was asked and questions and options were similar of this type. Going forward to next question, question number 85. This is Ballard scoring system with estimated gestational age in newborn can be started from which of following gestational age: 16, 20, 24 and 28. This is again very much important. You have to remember Ballard scoring starts at 20 weeks and to 44 week. Score is minus 10 to 50. You have to remember, just add plus 5 to the score and just add plus to the weeks. Very much important. And again, at what week scores and week are equal: 40 week, 40 week and 40 the score. So in this small table there are 5 MCQs. The range is 20 to 44 week, score is minus 10 to 50, and at 40 week score is 40. Okay, one more question. 5 score is given in which condition: physical maturity in skin if lethargy, cracked and wrinkled skin is seen, the 5 score is used, and if popliteal angle is less than 90, the score is 5. These two has been asked also. So in this question we are discussing actually 5 to 7 questions. Going forward to next question, a 4-year-old child present with pallor, decreased urine output and history of bloody diarrhea. Lab shows anemia, thrombocytopenia and elevated creatinine following most likely seen on peripheral blood smear. Basically, examiners have love affair with HUS. They ask HUS in some way or another way. So basically, they are asking of PBF finding HUS. Cystocyte should be the answer. Okay. Basically, HUS is a triad of microangiopathic hemolytic anemia, in the pallor, fatigue, jaundice, cystocytes are seen, thrombocytopenia and AKI. Okay, I have discussed HUS in detail, in very much detail in my HUS video of nephrology Nelson based video series. What you have to do, just go through the playlist in this channel. This is freely available and very much important topic. Just go through from there. Okay, next question, question number 87. 2-year-old child present with 4 days of fever and some mucocutaneous signs suggestive of incomplete Kawasaki. You decide further based on AHA guidelines. Which of the following is not routinely required in evaluation of incomplete Kawasaki? Again, just see this. This is screenshot of my rheumatology rapid revision class just 5 days, I think 3 to 4 days before exam. So where I discuss incomplete Kawasaki disease workup. Okay, so this question is exactly from there. If you are happen to do incomplete Kawasaki workup, children with fever more than 5 days or 2 or 3 compatible clinical criteria, or infant with fever is more than 7 days without other explanation, what you have to do, you have to assess laboratory test. If CRP is less than 3 and ESR is less than 40, you have to re-evaluate it. Okay, but just see, if CRP is more than 3 and ESR is more than 40, what you have to do for Kawasaki disease diagnosis, just do echo. If echo is positive, just treat the patient. But echo is not available or echo is not positive, 3 or more laboratory findings should be there to treat the patient or consider this patient as Kawasaki, anemia, thrombocytosis more than 4.5 lakh after 7th day of fever, albumin less than 3, elevated ALT, WBC more than 15,000, and urine is suggestive of more than 10 WBC per high power field. More than 3 should be required. Just pause this video. I'm going very fast due to time constraint, but just pause this video and revise this in complete Kawasaki disease workup. This is very much important. So in coming back to our question, this is CBC is required, urine WBC is required, serum albumin is required, ferritin is not required to work up. Okay, so this is concept based question, very much important. Going forward to next question, a 5-month-old infant present with prolonged jaundice, liver function shows conjugated bilirubin, liver biopsy reveals dark melanin-like pigment in hepatocyte. So what is the diagnosis? Again, the importance of keywords which is I'm emphasizing again and again. Dark melanin-like pigment in hepatocyte. Once you see this, conjugated hyperbilirubinemia question is there. Dubin Johnson should be the answer. Again, this is from my inherited hyperbilirubinemia disorders in pediatric. I have discussed them in this liver series of Nelson based liver series. I have separate video. Just go through in playlist and just see what we are discussing. Okay, this bile excretion, urine corpoporphyrin values are given, so which is important. Okay, again, I have compiled all Gilbert, Krilganaja, type 1, type 2, Dubin Johnson, Rotar. Basically, these are unconjugated, okay, and these are conjugated. I have discussed them that from the enzyme, from other things. So I'm not teaching this table. What you have to do, just pause this video and go through this table because this is very important. Just to highlight, this is actually I have highlighted important thing because mark decline. This is this black pigment. Okay, basically this whole table is important. Take your time, just revise it. Discussing it here is out of scope of our discussion. So again, to remind you all, we are discussing this NEET SS pediatric recall of recent 2025 conducted examination. Okay, any suggestions from your side or any things you want to convey to me or any question you want to get corrected, or if you find this option is not correct or this question is not exactly recalled, please comment down below. And for this initiative to get actually to motivate me to make more videos, just you need to do like, share and subscribe, and just hit the bell icon so it get spread, and just forward this discussion videos in your resident group of your college or your institute. Okay, so this should go way actually farther. Okay, coming back to our discussion, next question is what is following statement about patent ductus arteriosus is not true. Okay, so they are asking about PDA. So PDA's location is proximal to left subclavian artery. No, all we know it is distal to left subclavian artery. So this is wrong. It is not true. PDA connect pulmonary artery to descending aorta. True. Small PDA are asymptomatic. True. Continuous murmur is typical auscultatory finding. True. Okay, so this is upcoming question. Actually, screening criteria of PD in preterm infant is very much important. Less than 28 weeks, less more 29 to 30 week, and less than 32 week. Again, has been asked multiple times. Just go through these criteria. Very much important. I'm going to next question. Which is the most common site of metastasis in a child with neuroblastoma? Answer is bone marrow. This is typical image and can be asked in upcoming exams. This is neuroblastoma cell aspirated from bone marrow, and in this condition clumps of cells often seen more than 3. without evidence of rosette formation. So this is actually very much important. Going forward to next question, question 91. In case of AKI and GFR, which at which GFR dialysis indicated? Okay, so this is I think CKI. Yeah. So less than 15 ml per minute, 1.3 meter per square, AKI is dialysis indicated. So we have discussed this image like diagnostic criteria and this staging also. You have to remember this staging because this is very much important and repeatedly asked in exam. I have discussed this staging or a discussion of AK and CK in my nephrology video. You can refer there. Okay. So going forward to next question, a child with confirmed salmonella infection is in cardiogenic shock. Blood culture is positive and ceftriaxone has been started. What is next most appropriate management? Okay, so I am again referring Indian Academy of Pediatrics, what they say. Okay, steroids are indicated in only severe cases in enteric fever, in like shock, coma, altered sensorium, dexamethasone is given. So basically in enteric fever, steroids are indicated in shock and coma state and altered sensorium. Azithromycin is second line. Coming back to our question, in our patient is in shock. Okay, shock. So next step to add is this dexamethasone. Steroids are indicated. Azithromycin, yes, we can add, but these options are not. Azithromycin we can add, but dexamethasone because patient is in shock and shock is emergency. Okay, going forward to next question. SLE, sorry, 2-week-old infant with photosensitive annular rash on face. ECG shows complete heart block. Complete heart block, and this kid picture is itself sufficient to make a diagnosis of neonatal lupus. Again, I have discussed this neonatal lupus in my pediatric rheumatology based revision video just before NEET SS examination. Okay, what you guys to remember is this: neonatal lupus is important, and what you have to do, you have to do echocardiography at starting of 17 to 26 week. If echocardiography is normal, then postnatal is echocardiography at first month of life and first year of age are optional. If PR interval is more than 150, you have to consider dexamethasone very much important. But if it is a 2-3 AV block or CHF is there, you have to add IVIG. Just pause this video and revise this stuff again. Very much important, neonatal SLE. Going forward to next question, question number 94. In this condition, what they asked, tachypnea, vomiting, altered sensorium, and a child at ingested drug used by his father, respiratory alkalosis and hyperglycemia. This is also a question where exact recall is not available. So from the given description, aspirin should be answered because it causes ketoacidosis. Sometimes it's caused hyperglycemia, hyperapnea, glycosuria, ketonuria. But again, this question, if you find this question is incomplete, just comment down below and give your answer if you remember. Going forward to next question, a 20-day post hematopoietic cell HSCT transplant, a child developed jaundice, breathlessness, and difficulty walking. What is the most likely diagnosis? Again, this is straightforward question, concept based. This is sinusoidal obstruction syndrome, veno-occlusive disease. Okay, clear cut. It is mentioned in text. Okay, answer is clear. Going forward, a pediatric patient is significant risk of agiospermia associated with cumulative cyclophosphamide dose. 250 more than 250 milligram per kg should be the answer. It is milligram per kg. This is fact based question. Just remember, I think this is repeat question. Question number 97. A infant newborn delivered by a C-section developed tachypnea at 2 hours of birth. No significant retraction of grunting. Oxygen support is started. After 24 hours, the infant is well, off oxygen, feeding normally. What is chest X-ray finding suggestive of? By description, without seeing X-ray, I am able to conclude that this patient is TTNB. X-ray is also suggestive of TTNB. What they are asking X-ray finding of this? Uh, this is actually answer C. Prominent vascular marking are able to see and fluid in intralobar fissures. Question number 98, which is surrogate marker of ADH vasopressin in clinical practice. This is fact-based, straightforward question. Copeptin is the answer. Going forward to next question, second last question of this discussion. A patient presents with recurrent hypoglycemia, micropenis and prolonged neonatal jaundice. What should be the most likely diagnosis? It is actually congenital hypopituitarism. Very much important. Okay, just remember these two images, solitary median maxillary incisors and septic optic dysplasia, very much important. Last question, a child with delayed cry and spasticity and weakness of lower limbs but able to use his hand and feed himself. Basically, we are dealing with diplegic CP. The most common variety of this is actually periventricular leukomalacia. So periventricular leukomalacia. This we have concluded 100 questions, total 100 question, 50 from previous session, 50 from this session. Remaining question will be discussing them in part 3 video of this recall series. So again, I'm putting a lot of effort of collecting questions and providing appropriate explanation. So it's your work now to in comments put down comments, any discrepancy or any corrections or any suggestions you want. And just humble request from you all guys, just spread these videos in your resident groups or your pediatric groups. So because more stuff is coming in upcoming days in neonatology, in Nelson based videos, and because I think we'll be discussing it is very actually I love to interact with you guys. Just go through these videos again. This is very important for upcoming examination. So I'm stopping my discussion here. I'm just leaving you guys with discussion and analysis of this paper. Part 3 video is coming soon of remaining questions. Just give me suggestions of or collection of next topic, okay, you want to discuss in this series. Okay, till then, bye bye.